information in fertility.
Thank you very much for the generous introduction. And my task for today was to introduce you and explain you the Poseidon criteria. Originally, Peter Humaydon was the one to present this lecture, but as you heard before, he unfortunately cannot be present today. So on very short notice, I was asked to fill in. And at this point, I want also to acknowledge my friend Sandro Esteves, who provided me some of his slides and allowed me to use and to show it to you today. It's not possible not to repeat some of the information that you have already generally heard. We shall try to do and go more in depth in some of the issues. But being also a professional musician, I can tell you that repetition is the mother of excellence. So you will hear a lot of repetitions during the 2 days, and we hope by that you will be excellent in using the Poseidon criteria in your daily work. Now, studies have shown that female age is a negative predictor in outcome of ART treatment, and positive predictors are number of oocytes, numbers of the embryo transfers, but also the embryo quality. And you have heard already of this paper by Dracopoulos to show that the number of the oocytes will increase the probability to have a live birth rate by fresh embryo transfer, but especially the cumulative live birth rate during repeated embryo transfers. But when we look at the lower part with a low number of oocytes, as the Bologna criteria suggested, we can see that in different age groups, we have different probability to have a live birth rate from the same number of the oocytes, and this is data from the Swiss registry. Also, another paper showed that female age and the number of the oocyte can indeed predict live birth rate. And you have seen this already, of course. The criteria we are talking about now is not another poor ovarian response criteria, but a different mindset and looking at different results to try to stratify our patient, but especially the management of the treatment of this subgroup of patients that we are looking at. And as you can see here, also the picture of the entrance to the Poseidon thermals on Ischia when we gathered and came up with this idea and presented it in this first paper in Fertility and Sterility in 2016. Now, in order to classify our patient, we need markers. And first of all, we need good markers on ovarian reserve. And a good marker, according to our belief, should be a good predictor to the ovarian response to our stimulation. But a good marker should also tell us something about the quality of the oocytes that we are having and predict live birth. So we mostly use AMH and AFC, as you have seen, for predicting ovarian reserve and response. And it is actually a very good and accurate predictor, as you have already heard from Carlo, to predict the number or pool number of oocytes that you are going to achieve. But is it also a predictor for live birth rate? Well, it shows that it's not a good predictor of live birth rate because AMH and AFC are markers of quantity and not of quality of the oocytes. Age affects the number of oocytes, and this is also data from Sandro's group to show that the mean number of oocytes in advanced maternal age is getting lower and lower and lower. The quality of the oocytes is also influenced by the age. Mitochondrial function is impaired, granulosa cell number are reduced, and they are important for the end maturation of the oocytes. But also oxidative stress is increasing, and you can see here just on the example of the mitochondrial viability in 2 different age groups. This is data from my center. In Germany, we cannot use PGTA for aneuploidy of blastocysts, so we use polar body genetic testing, and this is looking now at about 5,000 oocytes. And oocytes are important, of course, in the advanced maternal age. This is the main problem, the euploidity of the oocyte. And you can see that up to the age of 35, you have a permanent decrease in the euploidity rate of the oocyte after checking the first and the second polar body. And this again from the paper of Sandro Esteves, you can see that the probability to have, looking now at blastocyst euploidity, the probability to have the euploid embryo will decrease age by age, and it is growing and becoming larger, the problem, as you go over the age of 40. And again, data from the US looking at euploidity of blastocyst, and you can see it's very much the same what you will see at the polar body testing for aneuploidity. So again, at the age of 40, you will have about 10 to 20% only euploid oocytes. Now, having a euploid oocyte or a euploid embryo will eliminate the age problem when you transfer the embryo. So on the right side, you see data from our chairman, from Filippo Baldi. Transferring euploid blastocysts will have no significant difference in the implantation rate. And on the left side, you see data from my center looking now after checking for polar body, and you see exactly the same picture. The pink ones are the ones who were tested, the blue ones are those who are not tested, and it's very much correlating. Doesn't matter if you test the polar body or you test the embryo by itself. And then we have to look to another aspect, like Carlo mentioned before, looking at the sensitivity of the follicles to normal stimulation with FSH. And as he mentioned before, we can use 2 different indicators nowadays. The FORT, the follicle output rate, having a low or a high number of embryos after a same stimulation with the same ovarian reserve, dissecting the patient into either normal responder or a hypo-responder. And we can use the new criteria that the Poseidon suggested, the FOI, the follicular oocyte index, where the cutoff points will be 50% of mature oocytes from the same amount of antral follicle count that you will start. Now, reason for that will be explained later on today by Dr. Conforti. And the main reasons are polymorphisms, or either the FSH and LH molecule by itself, or polymorphism of the receptor of the FSH and LH. And I just showed you a small example that about 25%, especially here in Europe, of the patient will be polymorphism of the FSH receptor, serine, which will affect your stimulation, or for the variant beta LH, more polymorphism of the molecule, about 15%. So 1 in 6 patients can be affected by this different molecule of LH, and they will influence, of course, the stimulation and the outcome of the stimulation. And when we look at hypo-responder patients, about 60% of them will have the serine FSH 680 polymorphism homozygote. Also, LH receptors, especially the LH312 serine, is known to affect the number of the follicles and oocytes that you can achieve from a standard stimulation. So taking now all this information together, so the age of the patient, biomarkers of ovarian response, and if we have the information of previous cycles and outcome, the fourth or the four information, or if we want to use testing for polymorphisms of the receptors or the molecules, we can put all this information together in order to classify our patients into the different prognosis groups that we are going to learn. So basically, we are using now age, ovarian reserve markers, and we have now two groups of patients. We have patients with good ovarian reserve, and we have patients with low ovarian reserve. And within these two groups, we have patients who are younger and patients which are older. So this is the idea of this classification. And we end up with these four groups. Group 1 and 2 differ by the age of 35, under or over, and the same with groups 3 and 4. Group 1 and 2 are patients with normal ovarian reserve, but with an unexpected, suboptimal or very low outcome of oocytes by the same stimulation protocol. And groups 3 and 4 are expected ovarian low number of oocytes because they have a poor ovarian reserve. And this is now the more modern way to show it, that you will see during the meeting today and also in some of our publications. It was explained the 35 years was, as you have seen now from my first slides, was the cutoff point where the euploidity rate of the oocytes start to change. And that's what it was accepted as the cutoff point between the left and the right group. And when we look at group 1, these are patients which are hypo-responders. So they will have a low fort or a low FOI and are hyposensitive to the standard stimulation with FSH. And they can be either very low in the number of the oocyte or just suboptimal. Group 2, again, hyposensitivity to standard doses of FSH, low fort or low FOI, and they are older than 35. So in this patient, the euploidity rate of the oocyte does make a difference. And for that reason, we shall need more oocyte to recruit, and we have to see how we manage that, and Filippo will tell you a little bit more about that in the next presentation. Now, groups 3 and 4 are patients with low ovarian reserve, so they are expected to have a low number of oocytes, and it is not possible because the FOI or the FORT are normal. There is no gonadotropins or anything you can do to increase the number of the oocytes which are not there. You cannot have any magic bullet to do that. So here again, we need to have management, special management, how to deal with the situation to reach at least one euploid embryo for the transfer, and that will be presented also in the next sessions. Now, Carlo already mentioned that when we validate the subgroups that we have looked to see how the cumulative live birth rate is, you can see here, first looking just at the Dracopoulos group, when we look at the Poseidon patient, they fall in the group with lower probability to have a cumulative live birth rate than those who have 10 or more oocytes. So this was obvious already before. But when we revalidate now the subgroups, it has been shown, we see taking all the Poseidon groups together, you see different probabilities to have a live birth rate, cumulative live birth rate within the Poseidon group by itself. But looking at all of them together compared to non-Poseidon patients, you see that the probability is about 50% lower to reach a cumulative live birth rate. So yes, it was validated, and you will hear more about it also in one of the next lectures. To go more into detail, we were right by choosing these 4 subgroups. Now, the Poseidon working group, as you can see, we worked very hard to put all these criteria together. We also decided of a new measure of a successful treatment. So what will be the end point of our management of the treatment? What do we want to achieve? And it was decided to have the ability to retrieve the number of oocytes which are necessary to obtain at least 1 euploid embryo for transfer at each patient. As I showed you before, from data from Filippo and our group, if you have 1 euploid embryo, you can, of course, eliminate the age problem in the probability to achieve implantation and live birth rate. So for this reason, you can also use the calculator, which Sandro Esteves especially developed, and he will explain it to you later in one of the next presentations, how it functions and how you can use it in daily work. And when you go home and you are now convinced that the Poseidon criteria and stratification will be helpful, you can look at the patient collective that you are seeing in your clinic. Look at the ovarian marker, look at the age of the patient, and try to stratify them into the 4 groups that we have mentioned before. And according to that, try to decide on the management how to treat this subgroup of the patient. So it's a very systematic way to put it into clinical daily work. And once you have stratified your patient in one of the subgroup, and you used the calculator to estimate the number of the oocytes that you need to reach 1 euploid 1, then you discuss with the patient the management that you think that they will need, and try to put it in not into words, but also into activity. So thank you very much for bearing with me today. And during the panel session, we shall have also possibility to answer your questions. Thank you very much.